I'm very happy to be here today. As a little background, I first got introduced to cannabinoids and CBD, THC, the whole concept. I was doing a presentation for a Parkinson's disease support group regarding pharmacotherapies used to treat the disease course. Completed my presentation and opened it up to the group for questions. And literally every question I got from the audience, the patients in the audience, was about the use of CBD and THC to treat their disease state. Not at all what I was expecting when I went in to do that presentation. But clearly what that really hit for me was that this is something that is on our patients' minds. It's something they're curious about, and they're looking to us to be able to provide them some answers to their questions. So what this presentation is going to be is really taking a little look at the history of cannabinoids, marijuana, THC, CBD, and its role in medicine, taking a deeper dive into some of the clinical pharmacology of cannabinoids, looking at the different ways that we can dose these medications and administer them, and then finally looking at some drug interactions and adverse effects related to cannabinoids. So this particular graph looks at the use of cannabis by adults 65 years and older. And you can see that it has steadily increased from 2015. Not shown on this graph, but by comparison, back in 2006, past year cannabis use in the same age cohort was only 0.4%. A 2019 Gallup poll focused on use of CBD products. 8% of respondents over the age of 65 reported use of CBD products in that poll. As compared to their younger age counterparts, older adults are more likely to report use of marijuana and cannabinoids for medical purposes, as opposed to non-medical reasons. Common reasons cited would be pain, arthritis, anxiety, loss of appetite, depression, and insomnia. So we'll take a look at the history and the regulatory status of cannabinoids. So the medical use of cannabis dates all the way back to 2737, where Shen Nung, a Chinese emperor, was one of the first individuals to describe the use of cannabis for medical purposes in his compendium. He described using it for things like treating malaria, constipation, rheumatic pains, childbirth, and even mixed with wine as a surgical anesthetic. So fast forward to the early 1900s and Western medicine gets introduced to cannabis. And during this particular time, it was really kind of the pinnacle of cannabis use in Western medicine. More than 100 different scientific articles were published in the United States and Europe. And in the late 19th to early 20th century, Americans were introduced to cannabis as in the formulation of cannabis Americana. And this was actually marketed by Merck, Bristol Myers Squibb, and Eli Lilly to treat pain, sleep, appetite, and digestion. Thereafter, cannabis prescribing in the United States dropped off significantly due to difficulties with developing a reliable and standardized way to prepare it, and there was difficulties with isolating the active pharmacologic ingredient within the plant. In addition, during this time, drug manufacturers were able to introduce a lot of other medications to treat many of the maladies that cannabis was being used to treat. In 1937, the Federal Marijuana Tax Act imposed federal restrictions on cannabis use and sale, adding an additional tax to the product, as well as restrictions in how it could be transported across from state to state, causing the use to fall off much more significantly. And then in 1942, the United States Pharmacopoeia removed it from its book as a viable medicinal agent. And then finally, the Controlled Substance Act classified it as a Schedule I controlled substance, deeming it highly addictive and devoid of medical use. And that was pretty much where cannabis stopped. Now, fast forward a few more decades, and we had research in cannabis being reignited. The chemical structure, THC, was identified in 1964, which really helped to kind of solve what was one of the active ingredients in the plant. Also during this time, scientists were able to successfully clone the receptors within our own brain for the cannabinoids. And they also were able to find cannabinoids that our body produces naturally. So we have our own cannabinoid and endocannabinoid pathway within our brain. Back in 1996, a California ballot initiative, Proposition 215, passed with 56% voter support, and this legalized medical marijuana in that state and really kind of ushered in a new phase for cannabinoids within the United States. And now by 2023, there are 44 states and the District of Columbia that have either active or pending legislation legalizing marijuana for medical or recreational purposes. At this time, though, these state regulations still exist in direct conflict with federal statutes, posing legal and ethical dilemmas for clinicians. Worldwide, Health Canada has the marijuana and medical purposes regulation, which allows medical cannabis for various conditions. And there has been a trend towards progressive decriminalization of cannabis for both medical and recreational use across the globe. So on to a little bit about the pharmacology and the composition of cannabis. So herbal cannabis is derived from Cannabis sativa, the plant. And this plant possesses at least 489 distinct compounds from 18 different chemical classes. And this includes 100 plus unique cannabinoids. The two that we're most familiar with and are probably most familiar to our patients are THC and CBD. Depending upon the particular plant, the relative concentration of CBD and THC and other cannabinoids can vary quite a bit. This varies based on the strain of the plant, the soil it's grown in, the climate conditions of its growth, as well as the cultivation techniques. Other compounds within the plant that also have a role in its effects in humans are terpenes, flavonoids, and phytosterols. Terpenes are those aromatic compounds responsible for the distinctive odor of the plant. These terpenes are actually believed to kind of synergize with the cannabinoids, creating something called an entourage effect. Kind of the ultimate effect is greater than the sum of the individual parts. So it can augment or help tone down some of the effects that patients might get from the phytocannabinoids themselves. Additionally, combustion, so when cannabis is smoked, that transforms the plant cannabinoids a further molecular step, creating additional compounds that aren't created when cannabis is ingested or vaporized. So both marijuana and hemp are derived from the exact same plant species. Marijuana is by definition a cannabis plant containing more than 0.3% THC. Federally, marijuana is illegal. Hemp, by contrast, by definition, is any cannabis plant that has no more than 0.3% THC. Where it gets really fuzzy, the Hemp Farming Act of 2018 actually removed hemp-derived products from Schedule I status of that Controlled Substance Act. So now hemp-derived products can be legally sold with certain restrictions from state to state. So both marijuana and hemp cannabis plants will produce various concentrations of those phytocannabinoids, including CBD and THC. There are no restrictions legally on any of those other compounds made by the plant other than the THC content. However, since marijuana plants themselves are considered illegal, any chemical that comes from a marijuana plant would by extension be federally illegal. So one question that frequently gets asked is, well, is CBD legal? Well, the answer is it's complicated. It depends. CBD that comes from a marijuana plant is federally illegal. CBD that comes from a hemp plant or a plant that does not contain more than 0.3% THC is federally legal. The US Food, Drug, and Cosmetics Act additionally makes it illegal to introduce into general commerce any FDA-approved drug product into a dietary supplement or food product. And because CBD itself is actually recognized and approved by the FDA as a prescription drug product, commonly known as Epidiolex, an anti-seizure medication, CBD-based products cannot be actively marketed then as a food or a dietary supplement. This would constitute misbranding per the Food, Drug, and Cosmetics Act. So while CBD derived from hemp can be legally sold, no health or therapeutic benefit claims can be made by the manufacturer. The FDA is very well aware that there are companies out there that are not in alignment with the Food, Drug, and Cosmetics Act, and is actively working to find resolution and provide additional clarity for consumers and healthcare professionals. A citizen petition was actually initiated on this particular topic, and ultimately the FDA responded that they do not intend to pursue any sort of rulemaking that would allow CBD within a dietary supplement or conventional food, but they are actively working to provide that clarity that are seeking. There is a work group, and they're committed to finding resolution. An additional factor that needs to be considered is the labeling accuracy of these products, because they aren't going through any sort of FDA approval process. They're marketed as dietary supplements and food products, and don't get that formal testing for labeling accuracy. So this particular study looked at 84 different CBD products and tested for labeling accuracy. And what they found was that only 30% of the tested products were accurately labeled. And this particular study was looking specifically at oils, tinctures, and vaporization liquids. Also concerning is that some of these products contained contaminants or had THC concentrations sufficient to produce significant psychotropic effects or cognitive impairment, and that THC content was not reflected on the label. Looking at 105 topical cannabinoids, looking to see the labeling accuracy here, only 24% were accurately labeled with the content of cannabinoids that were really in the product. Most were underlabeled, containing higher amounts of the cannabinoids than what was actually on the label. And in addition, 35% of the products had THC, and their labels had no mention of THC. So really, in summary, the mislabeled products might end up lacking therapeutic value, And if THC is unintentionally administered by a patient, it could cause adverse effects, and our elderly population would be particularly prone to these adverse effects. So on to a deeper dive into cannabinoid pharmacology. So our endogenous cannabinoid system, so that signaling pathway for cannabinoids that's within our brain, includes cannabinoid receptors. It includes endocannabinoids, or cannabinoids that our body makes naturally, and enzymes responsible for their formation and breakdown. The core function of the endogenous cannabinoid system can be best described as relax, eat, sleep, forget, and protect. It's all about homeostasis. The endogenous endocannabinoid system helps us respond to acute stress and really restoring our body to that state of equilibrium. So our endogenous endocannabinoids are anandamide and 2-arachidonyl glycerol. And they are made naturally by our body. And when they bind to cannabinoid receptors within our body, they produce a variety of physiologic processes, regulating movement, appetite, memory, mood, our sleep-wake cycle, inflammation, and pain circuits. So there are two primary cannabinoid receptors. CB1 receptors are primarily found in our central and peripheral nervous system, whereas CB2 receptors are concentrated in immune tissues. So the two main endogenous cannabinoids, so that anandamide and 2-arachidonyl glycerol, they stimulate these two G protein coupled receptors, CB1 and CB2. And so when CB1 is activated, it has effects on our cognition, memory, perception, control of motor function, and pain pathways. CB1 receptors are also the receptor that is responsible for the psychotropic effects of cannabinoids. CB2 receptors have an important role in regulating the function of our immune cells and the inflammatory processes. So during a state of stress, our body is actually savvy enough to be able to alter the balance of CB1 and CB2 receptors that are in our brain to help bring about the response that it needs to have in order to restore homeostasis and that state of equilibrium. In our body, anandamide has a slightly higher affinity or preference for binding to the CB1 receptor, whereas 2-arachidonyl glycerol really has no preference and will bind equally well to either of the two receptors. Importantly, when one of these cannabinoids is bound to the CB2 receptor, there are no psychotropic effects. That is a CB1 receptor mediated process. So looking at our phytocannabinoids, so these are the cannabinoids that come from plants, typically our cannabis plants. So THC is one of our phytocannabinoids, and very similar to the cannabinoids our body makes naturally, it binds to both those CB1 and CB2 receptors. THC has a little bit of more preference for the CB1 receptor, but ultimately will bind to both. And as a result, though, THC has the greatest psychoactive potency of the cannabinoids. Because remember that psychoactive result is the result of binding of a cannabinoid to that CB1 receptor. In addition to its activity at the CB1 and CB2 receptor, THC also interacts with our serotonin pathways, our glutamine pathways, and our dopamine pathways within the brain. So it has lots of other effects outside of just the cannabinoid system. Taking a look at CBD, CBD actually doesn't have very strong affinity for either the CB1 or CB2 receptor. And in fact, most of the effects that CBD has are mediated by other receptor pathway systems in the brain, namely serotonin, adenosine, as well as some effects on the enzymatic breakdown of the cannabinoids our body makes naturally. Additionally, CBD can actually help to modulate the effects of THC at the CB1 receptors to kind of take the edge off, so to speak, of the effects of THC on that receptor. So in sum, THC has mostly pain relieving, anti-emetic, and appetite stimulating properties, as well as those psychoactive effects, whereas CBD's primary role in medicine is in anti-anxiety, anti-inflammatory, and anti-convulsant effects without that psychoactive component. For visual learners, what we can see is that THC binds directly to the CB1 and CB2 receptors. This is very similar to our own endogenous endocannabinoids binding directly to those CB1 and CB2 receptors. So THC is most similar to the cannabinoids that our body makes naturally in terms of how it goes about generating its effects on the CB1 and CB2 receptor. By comparison, CBD or cannabidiol, really the bulk of the effects from CBD come from a whole host of other signaling pathways within our brain. You can see here that it's serotonin, it's adenosine, it's GABA, as well as blocking the breakdown of the endocannabinoids that our brain makes naturally. So it just makes our own body's endocannabinoid system work better. But really, ultimately, CBD has very little affinity for the actual CBD receptors in our brain. Looking at it a little bit differently, we can take a look at the actual clinical effects associated with the compound. So this is looking at THC. We can see the clinical effects that are most often associated with THC, and then shown below the clinical effect is the receptor pathway or signaling mechanism at play to generate that effect. And a similar way of looking at it for the CBD component within the cannabis plant. So there are many chemical varieties of cannabis. For patients who would go to a dispensary, they would be asked to select their chemovar, and which is really the variety or the balance of ingredients within their cannabis. Each chemovar will have varying concentrations of cannabinoids. The relative proportions or the ratio of THC to CBD is selected based on ultimately the clinical effects you are hoping to get from the product. Interestingly, in Canada and the Netherlands, cannabis that is marketed for medical use is actually grown under controlled and well-documented conditions licensed by the government. So patients really know what they're purchasing, what they're getting. Whereas in the United States, we really don't have any government-controlled standardization for testing and marketing of medicinal cannabis in terms of its potency and purity. Many dispensaries will group their chemovars by either THC predominant, mixed THC CBD, or CBD predominant. Consumers need to use caution and really consider buying from a medicinal dispensary that provides a certificate of analysis. This certificate of analysis will link up to additional testing done by the dispensary to show the potency and the purity and the levels of contaminants that are within that product. You can see here on the slide, that's in the upper left-hand corner of your screen is an example of a certificate of analysis to give the breakdown of what's in the product that they're buying. Due to the Schedule I federal status of cannabinoids, it is very difficult to conduct rigorous controlled studies of marijuana products in the US, which unfortunately does limit our understanding of the risks and benefits. This particular slide, I'm not going to dive into it too deep, but there are synthetic cannabinoids that are on the market as approved drug products. We have 3 in the United States: dronabinol, nabilone, and cannabidiol. Nabiximols is available in other countries, but is not currently available in the United States. Marinol and nabilone are both synthetic analogs of THC, whereas cannabidiol is an extract that is actually derived from the cannabis plant of CBD. You might be asking, though, we have FDA approved products from both THC family as well as the CBD family. Well, why do we even need the plant? Why can't our patients just use one of these? Proponents of using the actual plant will argue that the plant, whole derived plant cannabis, is because of that entourage effect and those other phytocannabinoids that come along, as well as some of those other ingredients that we talked about, we really get that the sum of the parts is greater than the whole, so to speak, that it's that entourage effect that we can't get from these synthetic cannabinoids. Looking at the kinetics and the pharmacodynamics, so kind of how our body acts on these phytocannabinoids, as well as kind of what our body does to the phytocannabinoid, as well as what the phytocannabinoid does to our body, and some of the drug interactions. So absorption, distribution, and metabolism will ultimately work together to determine the onset, the duration of action of each cannabinoid dosage form. Absorption is quite variable depending upon how the user administers. So both THC and CBD are very fat-loving components, making them have very low bioavailability, especially orally. So when inhaled, though, the peak effect is reached very quickly, within a few minutes, and then afterward rapidly declines. Oral administration is a more gradual process with a prolonged gradual increase in THC and CBD levels in the blood. Mucosal formulations like tinctures, lozenges, or sprays have more of an intermediate, somewhere in between the previous 2 modes of administration. And then topicals really are best left for localized symptoms. Their onset and duration is more variable. Systemic absorption is relatively low, so the effect is pretty much limited to the site of application. So inhaling cannabis is going to provide the most rapid onset of effect. And this is an advantage if you're treating something that's very acute or very episodic, where you need that quick response. The immediate feedback, or that you know it's working, is very conducive to self-titration of the dose. You know right away if you need to give more or use less. Smoking is one of the most common routes of administration. However, it is really not recommended due to the production of toxic byproducts from combustion, which increase the risk of respiratory adverse effects. Vaporization does produce less of these toxic byproducts. With the inhalation mode of delivery, you have to keep into mind, though, that factors such as the depth of inhalation, the duration of breath holding, as well as the vaporizing temperature can all affect absorption. Looking at oral cannabis ingestion, there's a substantially delayed onset of effect as compared to inhalation. In addition to the slower onset, there are lower peak levels, as well as a longer duration of effect. Cannabinoids, being that they're very fat-loving, are best absorbed in the presence of fat oils or polar solvents. So administration with a high-fat meal can increase the oral absorption. The variability in absorption, as well as that delayed onset of effect from when it's administered, can make it very challenging to titrate doses and achieve a consistent effect. A patient might take a dose, think it's not working, but it just really hasn't been fully absorbed yet. So they take more, and then by the time it starts working, now they have potentially stacked on top doses on top of one another. Oral formulations do have the advantage of being very convenient and discreet. Edibles like brownies, cookies, those types of things are very difficult to dose, highly unreliable in terms of clinical effect and drug delivery, and thus are not recommended. Mucosal or the sublingual or buccal mode of administration will use the epithelial cells in the tissue under our tongue and in our cheek to help absorb it. This bypasses the first pass metabolism in the liver, so it ultimately leads to higher concentration of the cannabinoids in the blood compared to oral. Onset of effect is a little bit faster than oral, but still not quite as fast as inhaled. It does allow for more accurate control of the delivered dose and assessment of the effect, because you're going to get your response in closer relation to when the dose had been administered. So it's easier to tell if the dose is working or not. And administration is generally more simple for patients as compared to the technique that is needed for inhalation and vaporization. And then lastly, topical. These are really ideal for localized symptoms or dermatologic conditions like arthritis. The systemic effect of this mode of administration is fairly limited because the cannabinoids are poorly absorbed from their site of application into the bloodstream. So on to some age-related considerations with cannabis use. So the pharmacokinetics of cannabinoids in older adults are altered as compared to the kinetics in our younger population. We know that our older adults have decreased hepatic function, decreased renal function, both of which are going to increase the half-life of CBD and THC in the body. Additionally, elders have increased relative fat stores as compared to our younger population, and we know that cannabinoids have that fat-loving property, and so cannabinoids are going to distribute into that increased adipose tissue and accumulate there and have that wider volume of distribution in the body. Additionally, elders have lower protein binding capacity in their blood, which cannabinoids are highly protein bound. And so without the protein in the blood to bind to, that means that there's more cannabinoid floating through the bloodstream, free and available to have pharmacologic effect. Ultimately, that's going to result in elders being more sensitive to the effects of the drug at any given dose. Cannabinoid absorption is more variable and less predictable in older adults. The data that we have on drug-drug interactions is relatively sparse. However, we know our geriatric population, polypharmacy is common. They generally are on more than one medication. So we can't ignore the potential for interactions. Our seniors we also know they have reduced cognitive and psychomotor reserves as compared to our younger cohort. And so seniors are going to be more sensitive to the cannabis-related neuropsychiatric effects, as well as the postural hypotensive effects of cannabis, which is going to predispose them to an increased risk for falls and cognitive impairment with the use of cannabis. Overall, there is a large knowledge gap concerning cannabinoids and their effects on older adults. This particular quote was from one of the papers I looked at when preparing this presentation, but less than 250 older adults have been included in cannabis studies to date. So much of what we know about cannabis and its role in pharmacology and medicine is from younger patients, and we are extrapolating that to when we are using these products in older adults. So taking a look at cannabinoid drug interactions, we do know that THC and CBD are primarily metabolized by the cytochrome P450 system, which is a huge metabolizing system within our body for drugs and other substances in our body. So medications that inhibit these enzymes, these drug metabolizing enzymes, are going to slow the metabolism of CBD and THC and increase the blood levels of CBD and THC. So if a patient happens to be taking an inhibitor and they are using medical cannabis, they're likely going to get a higher effect from their cannabis than someone who is not taking an inhibitor. Medications that induce these enzymes are going to lower CBD and THC levels. So a patient who's taking an inducer of one of these cytochrome P450 enzymes is going to be more apt to quickly metabolize the THC and CBD and get less of an effect as compared to someone who is not on one of the inducer medications. Drug interactions with cannabis will vary quite considerably in terms of clinical significance, especially since the variability in the composition of the products that the patient might be using, whether that's a THC predominant or a CBD predominant product. To date, however, clinically significant cytochrome P450 drug interactions with cannabis have proven to be very rare, albeit there are very limited human studies. Most of these interactions are theoretical. However, we do know that our elderly population is on more medications than our younger population, and also are more sensitive to some of the adverse effects of medications. And so even though these interactions may be theoretical, they still should be taken into consideration when starting a CBD or THC product in your patients. So CBD itself is also an inhibitor of quite a few cytochrome P450 enzymes. So that means that CBD, by inhibiting those enzymes, is going to increase the drug levels of drugs that get metabolized by those enzymes, increasing the effects of those drugs. Again, most of these have not proven to be clinically meaningful. However, again, with the caveat that most have not been well studied, and if they have been looked at, most of them are through case reports or case series and have not involved a well-represented population of elder adults. Most significant, however, THC is going to have additive effects with other hypnotics, sedatives, psychotropics, or alcohol. Because THC has those effects on that CB1 receptor where we get that psychoactive component, if our patient happens to also be taking another sedative or consuming alcohol, they are going to get additive sedative effect. In terms of adverse effects of THC and CBD and medical cannabis, adverse effects are relatively common with cannabinoids. Approximately 8 or 9 patients out of 10 will experience an adverse effect with cannabinoid therapy, and about 1 in 10 are going to stop therapy because of an adverse effect. The most common short-term adverse effects are THC mediated, which include the psychomotor impairment, feeling high, sedation, dizziness. Negative effects on your cognitive processing are especially concerning in our elderly population. Patients should be advised to avoid driving for at least 6 hours after consuming cannabis. Cannabis, we know, is associated with a 5 times greater risk of having a motor vehicle accident and a 2 times greater risk of a fatal or serious accident. Additionally, our elderly population should be cautioned of the adverse psychomotor effects, which could predispose them to falls or injury. In general, it's a start low and go slow dosing strategy. Cannabis does increase our heart rate, our blood pressure, and our myocardial oxygen demand, which can aggravate angina or trigger a myocardial infarction. There are case reports and epidemiological studies that link recent marijuana use to cardiac events. The risk does appear to be greatest when cannabis is smoked. We would need prospective studies to really fully assess the risk. However, in general, unstable cardiac disease is regarded as a relative as a contraindication to cannabis. When cannabis is smoked or vaporized, we do have a few additional adverse effects to take into consideration. What we know is that smoked cannabis contains tar and carcinogens. There's very limited links between smoked cannabis and lung cancer. It's not very clear if there is a link. However, chronic bronchitis has been reported. Additionally, some of the smoked formulations have additional impurities in them that need to be taken into consideration, such as heavy metals, herbicides, pesticides, mold spores, or bacteria. In general, we would avoid vaporized or inhaled cannabis in patients with underlying respiratory disease or asthma, COPD. Cannabinoid hyperemesis syndrome is also another side effect that gets attention. This particular side effect is characterized by cyclical nausea, vomiting, usually quite heavy, and usually the patient is a heavy user of cannabis. Interestingly, patients get temporary relief of their symptoms when exposing themselves to a hot bath or shower. So compulsive bathing is also another presenting symptom of the patient. The etiology of this particular syndrome is not well understood, but may be attributed to the effects of cannabis on the TRPV1 receptor. So interestingly, capsaicin, by opposing the effect of cannabis on that receptor, when applied topically to the abdomen, is actually shown some benefit in treating cannabinoid hyperemesis syndrome. So taking a kind of putting it all together, a global look of what should I tell my patients about cannabis, or how should I go about making a decision of if this is right for my patient or not? So really starting with, is this a plausible or established condition where cannabis would potentially be useful? I've listed some conditions there that do have some literature out there to support benefits of cannabis, things like neuropathic pain, palliative pain, cachexia, nausea, vomiting, seizures, and spasticity. The next question you got to ask is really assessing that risk versus benefit. Have other treatments been adequately trialed? Cannabis should not be your first line go-to agent for any of the above conditions or others. We really should be trialing other treatments first, and then looking at the potential, weighing that balance of the potential quality of life improvement that the patient might get from introducing cannabis into their regimen versus the risks that are going to come with that use of that product. Also considering the adverse effects, the potential drug interactions, any relative contraindications the patient might have, their underlying fall risk. If based on shared decision-making, it's determined that a trial of cannabis is warranted for the patient, we would trial with an exit strategy. We would start low, we would go slow. In general, for a route of administration, inhaled is not going to be your preferred route due to its the additional adverse effects, as well as the technique dependence of that mode of delivery. We're going to want to refer the patient to select a reputable products, whether that's from a dispensary in your state, whether that's from someone who is able to supply that certificate of analysis to really show the patient what is in that product. And then if at any point in time we're not getting the response we are hoping for, we encounter unacceptable side effects, we would stop treatment. We trial with the exit strategy. We aren't committing to stay on this. If it doesn't work and it's not doing what we want it to, we're going to stop it. When we choose a product that based on the cannabinoid content, we're going to choose that ratio of product based on what we're treating and what balance of receptor interactions we are hoping to achieve. So depending upon the disease state we're treating, that's going to guide which type of product we're going to pick. And then all throughout, it's really, does the benefit of continuing justify the risk? We might consider dose adjustments, changing our mode of delivery, evaluating presence of polypharmacy and removing interacting drugs, involving the family with monitoring side effects and identifying safety concerns. So with that, thank you for your time, and I will open it up for questions. So our first question is our 76-year-old with a past medical history of hyperlipidemia, osteoarthritis, Parkinson's disease, and osteoporosis. Patient has read about CBD oil and he questions if he should give it a try to help with his motor symptoms. So which would be the best response? And it looks like everyone picked B. Some people with Parkinson's disease have reported symptomatic benefits from cannabinoids. However, high quality research is limited. The use of CBD oil should involve an individualized risk-benefit decision. And so that is the correct answer. ES decides he wants to give CBD oil a try. Which adverse effects would you educate him about? Looks like most people picked answer C, which is sedation, dizziness, and short-term memory impairment. And that, of the answers there are some intermixed throughout some adverse effects that would show up in the other answers, but of the answers, that's the one where all three really are known adverse effects of our cannabinoids.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.